Hello, friends. So today I'll be giving a brief overview on the diaphragmatic assessment in ICU. So at the outset, I wish to acknowledge my colleagues, Dr. Pratibha and Dr. Karthik Ravikanti, who have helped me to develop this content by giving images within our ICU. So when we look at diaphragmatic in critical care, what do we know so far? So when we look at the diaphragm, so diaphragm can undergo atrophy in intubated and mechanically ventilated patients. And atrophy of the diaphragm is associated with increased duration of mechanical ventilation because this would contribute in having difficulty in weaning from the ventilator. So atrophy or wasting of the diaphragm can increase the duration of mechanical ventilation, increases the ICU length of stay, and can increase the complication rate. So on one side, diaphragm has a propensity to get atrophied in someone who is on complete ventilation and who are on neuromuscular blockers. On the other side, even in ICU, there can be increase in the thickness of the diaphragm. And this thickness can happen in acute situation where there is lot of edema formation within the diaphragm, possibly due to over resuscitation and due to third spacing and other sort of a waterlogging condition. There could be increased edema of the diaphragm, which can lead to increased thickness. And this also increases the risk of patients undergoing mechanical ventilation. The thickness reduces in ICU who are mechanically ventilated. The thickness of the diaphragm reduces by 6 to 7.5% per day. And in children, the thickness of the diaphragm reduces by 3.5% per day in children. So this is a natural progression in someone who is mechanically ventilated. The thickness or there is a progressive atrophy of the diaphragm that can tend to happen. So ultrasound of the diaphragm helps in ascertaining various aspects of diaphragm. So the diaphragm can help in determining the excursion of the diaphragm. So we will talk about it. And then the ultrasound of the diaphragm helps in ascertaining the time for peak inspiratory amplitude, which we call it as TPIA. So this is also, we will go through the way we would ascertain the time to peak inspiratory amplitude. And ultrasound helps in ascertaining the thickness of the diaphragm and the thickness fraction of the diaphragm. So these are certain things that we could do to ascertain the function of the diaphragm in ICU. So one is excursion, one is the time to peak inspiratory amplitude, and the third one is diaphragmatic thickness and thickness fraction of the diaphragm. So how do we look into the diaphragm? So we could look into the diaphragm by using curvilinear probe or the linear probe. Mainly, so curvilinear is useful when we are doing subcostal view. So in the mid-clavicular line, in the subcostal, we need to place the ultrasound probe. So when you look at the diaphragm, will be looked at as a glistening sort of a picture, a glistening feature. So at the end of inspiration, so you would see there will be movement of the diaphragm during inspiration, expiration. At the end of the inspiration, you would have a picture like this. And during expiration, the diaphragm tends to move on and you would see something like this. So by putting a cursor on this, we can get an M mode of diaphragm and we can look at the diaphragmatic excursion. So by putting on an M, so we put a M mode cursor on this diaphragm and we get a sort of a diaphragmatic excursion. So as you would know, so this is the end inspiration. So end of inspiration will be the top one and the below one will be the end of expiration. And we measure the distance between the end of inspiration and end of the expiration excursion. And for the weaning, it should be more than 10 millimeter, this distance. So ideally 11 to 13 millimeter is the normal excursion. So anything more than that is always good. So if we have excursion less than 10 millimeter, it indicates that there is possibly some diaphragmatic dysfunction and we possibly may have difficulty in weaning. So this is the diaphragmatic excursion we look at, the first aspect. Then the second thing we look at is time to peak inspiratory amplitude, which we'll talk. So this, as you see, when you take a normal inspiration, we call this as tidal inspiratory efforts. Then we ask the patient to take a deep inspiration, then you would see there would be an increase in the peak. So this would be the deep inspiratory efforts where you would see an increase in the peaking of the inspiratory effort. So the second aspect that we would look, so the first one is we look at the diaphragmatic excursion More than 10 millimeter is what we need. 11 to 13 millimeter is considered good. So more than 13 millimeter is a good diaphragmatic function. Less than 10 millimeter is less. So then we look at the time to peak inspiratory amplitude. So time to peak inspiratory amplitude, again, we put the M mode on the diaphragmatic, and you would get a similar wave like this. So this is the height of peak inspiratory excursion. So we look at the time taken for this diaphragm to reach the peak, and that's what we call as time to peak inspiratory amplitude. So this time taken from B to A, either here or here, is called time to peak inspiratory amplitude. And less than zero point 0.9 seconds. Generally, this is based out of one study done by the Thai group, and that has taken as a reference. So less than 1 second, so maybe less than 0.9 second is taken as diaphragmatic dysfunction and non-venable. And if you have more than 1.2 seconds, so this distance, that would qualify as possibly successful weaning. So 1.2 to 1.3, you can keep it as successful weaning. Less than 0.9 indicates diaphragmatic dysfunction and non-weaning. So this is the image we acquired from our own ICU. So we had an interesting patient with a diaphragmatic dysfunction due to myasthenia gravis after CABG surgery. After post CABG, this patient went into myasthenic crisis, predominantly involving diaphragmatic. So here, as you see, we had given IVIG and we did the diaphragmatic function. If you see, so this is the peak. So as you see, the time here is 1.28 seconds, which means we did this ultrasound, determined that the diaphragmatic function is good, and then we extubated him. So, and it was a successful extubation because initially he had failed an extubation. As you see, the time is 1.28 second on the right side, and that suggests that that this would concur with this successful sort of a weaning process. So this is how we would do it. So here you see there is a time taken from baseline to the peak of inspiratory excursion. So that is the second aspect. So we did the diaphragmatic excursion. It should be more than 10 millimeter, and time to peak inspiratory amplitude. Ideally, it should be more than 1.2 to 1.3, which is taken as a indicator for good weaning. Then the third aspect we look at is diaphragmatic thickness and thickness fraction of the diaphragm. So these are the things that we would look at. So diaphragmatic thickness, we again look at inspiration and expiration. So we look at both and we ascertain. So the diaphragmatic thickness, we look at this region. So this is the region, costophrenic angle, where there are opposition of the parietal pleura and the peritoneum and the pleural space. So there will be opposition of these structures and the diaphragm. So here we would see, so there is a parietal peritoneum here. So this is the diaphragm. So this is the lung, and this is the pleural space, and then you have parietal pleura. So this is a important area, costophrenic, where there is opposition of these structures happen, where we look at the diaphragmatic thickness. So for diaphragmatic thickness, again, we place the curvilinear probe in the anterior axillary line at the area of costophrenic angle where you see the diaphragm. So the diaphragm will look something like this. You'll have a peritoneal layer, you have a pleural layer, and this is the diaphragm. And we take again this one during inspiration and expiration. So we use 6 to 13 hertz ultrasound is what is recommended in M mode. And diaphragmatic thickness is taken both during end inspiration and end expiration. And diaphragmatic thickness difference is calculated by diaphragmatic thickness during inspiration minus diaphragmatic thickness during expiration. And thickness fraction diaphragm is calculated by the difference of diaphragmatic thickness difference divided by diaphragmatic thickness during expiration into 100. So although it looks little complex, it's very simple to do. I will show you how we have done in our patient. And the thickness fraction of diaphragm less than 20% indicates dysfunction. So ideally, we want the thickness fraction of diaphragm to be more than 30% to be having effective weaning. So less than 20% indicates dysfunction. So this is how the diaphragmatic thickness will look. During end expiration, it looks small. During end inspiration, it looks much bigger. So basically, we take during end inspiration, end expiration, calculate the difference between these two divided by diaphragmatic thickness during expiration into 100. That gives you fractional thickening or the thickness fraction of the diaphragm. So again, these are some of the pictures. As you see, so this is end expiration, A and A. B and B is the end expiration. So expiration will be smaller, inspiration will be bigger. As you see, inspiration, as you see is here, is much larger and expiration is lesser. And this is how it looks when you look into the ultrasound. So diaphragm will be seen in between. There will be a pleural line and there will be a peritoneal line and there is a rib there. So these are just the different pictures I'm showing. But how we see when we do it in our ICU, it looks something like this. I'll show you our own pictures. So this is the intercostal muscle. So this will be the liver. So this is the diaphragmatic sort of a thickness we look at during end inspiration. So as I said, end inspiration, diaphragmatic thickness will be more. During end expiration, diaphragmatic thickness will be less. So this is the picture we took in our ICU for this patient with myasthenic crisis involving the diaphragm. So as you see, we have taken during end expiration. So this is the peritoneal line, this is the pleural line, and this is the diaphragm. So here you see it is 0.49 centimeters during expiration. And we have taken during inspiration. As you see, inspiration, it becomes bigger. And the thickness fraction of diameter, here it's come as 0.68 during inspiration. So 0.68 minus 0.49, which we got during expiration, divided by expiration, which is 0.59, we got 38%. So 38%, as you saw, the thickness fraction of diaphragm is 38% is a good sort of a fraction, which will suggest that effective weaning will happen. And we looked at the time to peak inspiratory amplitude, which was more than 1.2 seconds, again, which is going to suggest that weaning is going to happen effectively. So where is all these numbers derived from? It's derived from this particular study by Kwan Z et al., which came in BMG. This was a meta-analysis of 11 studies, including 436 patients. There were 8 studies which looked at diaphragmatic excursion, and there were 5 studies which looked at thickness fraction of the diameter, and both of them were found to have a good diagnostic performance in ascertaining a good weaning. And diaphragmatic dysfunction was concluded as a good predictor of weaning failure. And as I said, diaphragmatic excursion, as I said, should not be less than 10 millimeter. 11 to 14 millimeter had a good sensitivity and specificity to indicate effective weaning will happen. And thickness fraction of diaphragm, as I said, our patient had 38%, 30 to 36% suggests that good weaning will happen. So if it is less than 20%, definitely they are going to fail weaning. And that was found to have increased sensitivity and specificity. And it is suggested from this particular paper that all these weaning indices should happen before extubating the patients to make sure that they would have successful extubation. So this is about, in brief overview, about diaphragmatic sort of assessment in ICU. But one important message to all the listeners is that assessing only diaphragmatic function as indicative of someone who would wean is something that one should not take. This has to be combined with assessing your other cardiac function and other weaning parameters and so and SBT trials and others, so on and so forth. So this is used mainly as an adjunct to the other weaning indices to ascertain that effective weaning and extubation could happen successfully. So as I said, we use this indices, which was very useful for especially myasthenia gravis, where diaphragm was involved. And this weaning indices really helped us in successfully extubating our patient without getting into a crisis sort of a situation. Because initially he had failed extubation, and then after IVIG, we constantly kept assessing the diaphragmatic function, and only when our excursion was more than 10 millimeter and the time to peak amplitude was more than 1.2 seconds, and the thickness fraction of diaphragm was more than sort of a 30 to 36%, as I've indicated, we extubated him successfully. So this was a stellar example as to where we could use this modality. So to summarize, it will be the 3 important things that you would look. So diaphragmatic excursion, which is a very simple thing that you would look at, more than 10 millimeter it should have, and time to peak inspiratory amplitude should be more than 1.3 seconds, 1.2 to 1.3 seconds to indicate that successful weaning will happen. And fractional thickening of the diaphragm also should be good enough. So fractional thickening of diaphragm of 30 to 36% is the ideal. So less than 20% indicates diaphragmatic dysfunction. So thank you one and all. So I end with this beautiful quote. So you can rehear to this lecture on my YouTube, or you can visit my website www.drpradeeplangappa.com to read to this lecture. So thank you, one and all.